Hello and welcome to the series of masterclasses on cutaneous manifestations of systemic diseases for my Doctors as Teachers project. And this one will be focusing on a respiratory system. The first cutaneous manifestation of respiratory disease that I'd like to discuss today is cyanosis. Cyanosis is the blue or grey discoloration of the skin and your mucous membranes due to reduced oxygen saturations. Now you can have central cyanosis where you have a blue or grey tinge to areas with thin epidermis such as your lips or your tongue, or you could have peripheral you can have peripheral cyanosis, and these will be identified in the extremities, for example, your fingers. Now, the detection of cyanosis really varies with skin pigmentation, and peripheral cyanosis may be difficult to identify on patients with darker skin tones. So I've put a picture there just to demonstrate at the bottom right hand side of the screen what peripheral cyanosis would look like in an individual with a darker skin tone, and then the picture at the top is demonstrating central cyanosis of the lips and showing that blue grey tinge discoloration of the skin there in someone with lighter skin tone. So the next skin manifestation of respiratory disease I'd like to talk about is nail clubbing. Nail clubbing is one of those things that we get asked about quite a lot on placements. We get asked what causes clubbing, and I personally struggle to remember, so I found this acronym, or using clubbing itself as an acronym to remember the causes of clubbing. So what is nail clubbing? So nail clubbing is where you have a thickening of the end of your fingernails and you have an increase in your nail fold or convexity in a way, and your nail has a soft texture, and you lose what you call the Chambrot's window on clinical examination, and that's when you ask patients to put their two index fingers or two fingers together, and you're looking for a little window, and if that window isn't there, then you can conclude that that's this clubbing happening. But usually you could just kind of hold the patient's hands and just have a look across, and you should be able to pick up clubbing doing that. You don't necessarily have to use Chambrot's window. So using clubbing as an acronym to remember the causes of it, you have C for cyanotic heart disease, L for lung diseases, and the L has an extension of A, B, C, D, E, F. The A is for lung abscesses, B is for bronchiectasis, C for cystic fibrosis, and the D is there to help you to remember that you do not say COPD. E is for empyema, F fibrosis, and the U for ulcerative colitis or Crohn's. Just remember that ulcerative colitis is an inflammatory bowel disease, and then you can just include Crohn's into that. The first B is for biliary cirrhosis, second one for birth defects. I is for infective endocarditis, and I discussed other cutaneous manifestations of infective endocarditis in the cardiovascular system video. So if you haven't watched that, I would go back and have a look at that. But infective endocarditis also causes nail clubbing, as well as the other cutaneous manifestations that I mentioned in the other video. The N is for neoplasm, for example, lung cancer or mesothelioma, and then the G is for gastrointestinal malabsorptions, for example, celiac disease. So I really hope that this will help you remember the causes of clubbing, and next time you're on placement and you get asked causes of clubbing, you would be able to just give at least 6, if not more, causes of clubbing. So the next respiratory condition that I'd like to talk about that has dermatologic manifestations is sarcoidosis. Now, sarcoidosis is a multi-system disease, and it's quite complicated, and I would not have enough time to discuss it in detail in this one masterclass, so I'm just going to focus on cutaneous manifestations of it. So just being able to pick up signs on a clinical examination, sometimes from by just looking at a patient, you could be able to see signs of sarcoidosis or signs that may suggest that you need to investigate for this condition. So the first skin manifestation I'd like to talk about is lupus pernio. So lupus pernio is kind of a bluish, sometimes pink or red, very non-specific nodule or plaques. They tend to occur over the nose, the cheeks, and sometimes ears. And there's this scar sarcoidosis, and scar sarcoidosis is basically just a scarring due to skin fibrosis. And then you have erythema nodosum. Now, erythema nodosum in sarcoid is seen usually in the early stages of the condition, and erythema nodosum is one of those very non-specific lesions. It's associated with many other conditions, and I will discuss some of those conditions in my other masterclasses, so please stick with me. In terms of management of the cutaneous manifestations, they tend to go as you manage the underlying condition, which is sarcoid. So systemic corticosteroids would usually be helpful here, and then some biologics as well, for example infliximab or adalimumab. So moving on to tuberculosis. So tuberculosis is an infectious disease caused by the microorganism Mycobacterium tuberculosis. It generally affects the lungs but has extrapulmonary manifestations, and apart from skin manifestations, which we call cutaneous TB, also known as lupus vulgaris, there are other extrapulmonary manifestations, for example those that affect the central nervous system, such as TB meningitis. The adrenal glands can lead to Addison's disease, bones and joints that can lead to Pott's disease. Now, lupus vulgaris, as you can see here, is a reddish brown lesions, and they kind of have a gelatin-like consistency, and they're usually known as apple jelly nodules. These nodules or this lesion can last for years and years with tuberculosis, and can eventually lead to skin cancer. So it's really important to be able to pick up lesions like this on a clinical examination. Lung cancer is another respiratory condition that has cutaneous manifestations. Cutaneous mets in lung cancer are found in about 2 to 8% of lung cancer cases, and they commonly affect the abdominal wall, the neck, and the scalp. So the first manifestation I'd like to talk about relating to lung cancer is what they call tripe palms. Now, tripe refers to the stomach lining of beef, pork, or sheep. So you have this thickened, velvety palms from just proliferation of skin cells. This manifestation is usually seen in conjunction with acanthosis nigricans, and acanthosis nigricans is just hyperpigmentation and hyperkeratosis of skin folds, for example, in your axilla or your neck creases. Now, when tripe palms is seen with acanthosis nigricans, it's commonly seen in stomach and lung cancer usually. And if you have tripe palms without acanthosis, then you'd be really suspecting an underlying lung cancer. Now, tripe palms is one of those things that can persist even after remission of the underlying cancer. So it's a good clinical sign to be able to look out for if you've missed parts of someone's history, for example. The next manifestation is a thrombophlebitis. Now, thrombophlebitis is just a blood clot that blocks the veins near the surface of the skin, and you get this kind of reddish rash around the area. Looks a bit erythematous and inflamed. And finally, you have acquired ichthyosis, and this is where you get dry fish scale-like skin, and it can be caused by other things, for example, Hodgkin's lymphoma or HIV, underactive thyroid gland, and some drugs can cause this manifestation as well, such as hydroxyurea. So this is what your ichthyosis would look like on someone with of a darker skin tone. So the final lung-related condition that I'd like to talk about is yellow nail syndrome. Now, I think this is quite rare, but your yellow nail syndrome is a triad of, as it says, yellow nails, lymphedema, and pleural effusions. Now, it's thought that this syndrome is as a result of just accumulation of exudative, protein-rich fluid in soft tissue layers. So you have lymphedema, which is just swelling caused by blockage of your lymphatic system. Pleural effusions, where you've got fluid around the lungs. And you would be able to pick this up quite quickly by just looking at the patient's hands. You'd be able to see onycholysis, which is where your nail separates from the nail bed. You'll be able to see loss of cuticle, and just from taking a history from the patient, they'll be able to tell you that the nail is very slow growing. And that concludes the end of this masterclass. I hope that you've found it very helpful.